Good afternoon, everyone. Thanks for coming today. Today's meeting of 12 March, the Active Health and Active Lifestyle Scrutiny Board. Just for everyone's information, today's meeting is being webcast live on YouTube, and it's obviously a public meeting. For those watching online, you can find all our papers on the council's website or just put into a search engine Leeds Adults Health and Active Lifestyle Scrutiny Board. It's always the first result when I search for it. And we've got a slightly different meeting today. So normally we have a number of items and we sort of keep them quite separate. But today we're going to put them all together. So there's a lot of people around the table and we're going to go through each item as an appendix, but everyone will stay and we'll have a conversation because there's a lot of integration across the papers. So I think we're going to try it this way today and see how it works and consider how we do other papers in the future. But clearly, when items affect many different departments, I think it's quite helpful to talk about it all together. So with that, I'm going to go into introductions. So I'm Andrew Scopes, I'm Councillor for Beeston Holbeck, and I am the chair of this committee, and I'm going to go round to my left. Thank you.
Thank you, Chair. Luke Farley, Labour Councillor for Bermondsey and Richmond Hill.
Mohammed Iqbal, Labour Councillor for Hunslet and Riverside.
John Beale, a member of the board of Health Watch Leeds and a co-opted member of this board.
Councillor Mahaly Fransmere from Walltown and Meanwood.
Good afternoon, Councillor Taylor from Chapel Allerton.
Good afternoon, Councillor James Gibson, Crossgates and Winmore Ward.
Good afternoon, everyone. Councillor Kevin Ritchie from Bramley and Stanningley Ward.
Good afternoon, everybody. I'm Councillor Salma Arif. I'm the Executive Member for Adult Social Care, Public Health and Active Lifestyles.
Good afternoon, everyone. Victoria Eaton, Director of Public Health at Leeds City Council.
Hi, I'm Jane Wallen. I'm Chief Officer for Active Leeds and Operations in City Development.
Good afternoon, I'm Stephen Baker. I'm the head of Active Leeds.
Good afternoon, I'm Helen Lewis, Director of Pathway Integration for the Integrated Care Board in Leeds.
Good afternoon, I'm Ram Krish. I'm Clinical Head of Portfolio from Leeds Community Healthcare.
Hello, I'm David Wardman. I am a clinical lead for long-term conditions for the West Yorkshire ICB.
I'm Dr. Marcus Julia. I'm a GP and I sit on the Long-Term Conditions Health Population Board.
Good afternoon, Jim Barwick, Chief Executive of the Leeds GP Confederation.
Good afternoon, Heather Thompson. I'm Head of Public Health for Health Improvement and Healthy Living.
Good afternoon, Anna Ross, Head of Public Health, Children and Families.
Hi, I'm Catherine Ingold, Consultant in Public Health and Chief Officer for Children and Families.
Hello everyone, I'm Anna Ferguson. I'm a Consultant in Public Health for Healthy Living, Leeds City Council.
Hi, I'm Councillor Winkage representing Morley South.
Good afternoon, Councillor Paul Alderson from Guiseley Road and Ward.
Good afternoon, everybody. I'm Councillor Caroline Anderson. I represent Adlin Wharfdale Ward.
Good afternoon, I'm Angela Brogdon, the Principal Scrutiny Advisor.
Super. Thank you, everyone, and thanks for coming today. I'm going to hand over to Angela for the first few items.
Thank you, Chair. Under item 1, there are no appeals against the refusal of inspection of documents. Under item 2, there are no items for exclusion. In relation to item 3, there are no late items. And under item 4, please may I ask if board members have any declarations of interest? And I shall take silence as none. Thank you. Under item 5, we have received apologies from Councillor Hartbrook, and we also have apologies from Caroline Barrier as the Director of Adults and Health. Thank you.
Thank you very much. Okay, we're going to move on to the minutes. Can I first ask if the members are happy they're an accurate record? Yeah, I can see everyone, no one indicating that they're not, so I'll accept those. And then into matters arising. Angela, do you have any matters arising?
Nothing specific at this stage, Chair. Obviously, I appreciate this is the last planned formal meeting, so the information, the requests that have been asked for earlier, I'll ensure that they get circulated once I've received them.
Thank you very much. Matters arising from any members? I can't see anyone indicating, so I'll move on to item 7, which is supporting healthy weight and active lifestyles. So as I said, I do want to come in, Councillor Kitchen.
Can I just say about the last meeting we did, I thought the drugs and the suicide was very, very well put together and very informative, and I've just got to say a massive thank you to you people. It was very good. Thank you.
Thank you. And I agree with that. And I think it's worth noting that I felt like members dealt with the topic in a sensitive and appropriate and professional way. So I thought that was very, very positive. Yes, thank you. Okay, so on to item 7. So this is supporting healthy weight and active lifestyles. And as I said earlier, we're going to have it as one big discussion, but we've got 4 appendices. So there's 4 slightly different topics. But obviously, it's cross-cutting. And so as we go through, if you want to comment, ask questions after each sort of short presentation, we'll go into that, and then we'll have any further comments at the end as well. So with that, I'm going to hand over to Councillor Arif to start, and Anna Fearson for paper 1. Thank you.
Thank you, Chair, and Councillor Kidger, thank you for your very kind comments in relation to the previous scrutiny meeting. I totally agree, it was a really good, varied conversation. So the report covers a number of parts of my portfolio, starting with public health work on healthy weight. We know that excess weight can lead to serious health consequences such as cardiovascular disease, type 2 diabetes, and some cancers. These conditions can cause disability and premature death. Obesity can reduce life expectancy by an average of 3 to 10 years. And we also know that mental well-being can also be affected, with both adults and children more likely to experience poorer mental health. The proportion of adults and children who are overweight or living with obesity remain high in Leeds and nationally. The reason behind these high levels of excess weight are complex. However, 2 of the main factors are an increasingly unhealthy environment and the extensive marketing and availability of cheap, nutrient-poor food, which is high in fat, sugar, and salt. Although more action is needed at a national level, there are many interventions at a local level to create an environment that leads to a healthier weight. This report outlines our 4 strategies and plans which support healthy weight in the city. These are the Healthy Weight Declaration, Leeds Food Strategy, Adult Healthier Weight Plan, and the Child Health Weight Plan. The intention is to work towards a single healthy weight plan covering adults and children. Chair, I look forward to the views of scrutiny on our future approach around healthy weight, and I'm sure it'll be a really interesting discussion and really great to see lots of different partners in the room as well. Thank you.
So I'm just not going to be very long, but I just wanted to make a few key points. And I know Councillor Scopes, you wanted me just to talk about BMI and just explain that as an indicator. So I'll just do that first. So body mass index is calculated by measuring a person's height and weight. That's weight in kilograms divided by the square of their height in meters. It's not a perfect measure because it doesn't directly assess body fat. For example, muscle and bone density are much heavier than fat. So if you're a muscular person, unlike me, you may have a high BMI, but for most people, it's a pretty good measure. So I just wanted to, I suppose, just really emphasize the scale of this issue. So we're talking about 2/3 of adults in Leeds who are overweight or living with obesity. That is a lot of people. There's a strong link between obesity and deprivation. And then Catherine was just going to tell you the children's statistics.
Yes, for children, we usually look at data around children living with obesity, but when we look at overweight and obesity combined, it's around 21% of children in reception live with overweight and obesity, and 37% at year 6. These are very, very similar to national data, although in Leeds, as you'll know, our population of children, 1/3 of children live in the 10% most deprived, and children living in deprived Leeds, the rates are double that.
I hope it comes through in the report. But to address the issue of healthy weight, we need a system-wide approach with an emphasis on changing the environment, and particularly the environmental and commercial factors that affect food intake. Overly focusing on individual lifestyle interventions is of limited effectiveness, has a low return on investment, and will not benefit many people, particularly not people who live in more deprived areas. There's a strong association between high levels of deprivation and more unhealthy food. Thank you.
Super, thank you very much. Just so members are aware, at the moment we're looking at pages 16 to 37. So if you want to ask a question on this appendix, please indicate. Just to start with, I know we just talked about children's levels. So on page 19, there's a chart. I know we've made some really positive progress with the Henry programme in Leeds. But I think that was before COVID. I'd just be interested to know how our trajectory has been sort of the last few years. Thank you.
Yes, so in the COVID years, we were really alarmed. Childhood obesity rose by 4 percentage points. It was absolutely unprecedented. We are pleased and relieved that for reception age children, they have dropped down to pre-lockdown levels. For children in year 6, they are still slightly higher. But in Leeds, they are very similar to the national average, which obviously we would like them to be lower, but given that a third of our children live in the 10% most deprived areas, we feel that is a success, although there's so much more we need to do, and we're very well aware of that.
Thank you. And you also mentioned about the availability of certain food types. And I guess my take is there's limited power the council has to change that and affect what is available. And we were talking actually in the pre-meeting around the availability of fast food products and the ease of those. And I just wondered if you had any comments about what could be done to change that availability and where would that power sit? I'm going to bring in Sam and then I'll come back to you, Anna. Councillor Arif, sorry.
Thank you, Chair. I think it's a really important question. And I think it's just worth noting, just going back to your previous question as well, and Catherine's answer, in relation to lockdown, we did see high levels of children in deprived areas. And the reason for that was because a lot of them didn't have access to green spaces, particularly if they don't have any back gardens. So it was really difficult. And I think it's good to see that we're heading in the right direction. Now, to come back to your second point, in relation to the limited power that the council has. So as somebody who represents an inner city ward like Gipton and Hare Hills, particularly in Hare Hills, we've got high streets there's lots of takeaways, and the problem we've got there is the lack of control as a council to stop the influence of high saturation of takeaways. Now, what works really well in an area like Hare Hills, and we have seen, is the CIA for off licenses, where we've been able to successfully, through the help of public health and various different colleagues, stop the saturation of off licenses. It'd be absolutely fantastic if we were able to, as a council, to have powers to do something similar, because if you've got access to really cheap food, and particularly in the cost of living crisis, for some parents, a healthy option, it's cheaper for them to go to a takeaway. But it is really concerning for me as an elected member to see the level of, or the sheer number of takeaways in the area. So I think it'd be fantastic if we as a council had the powers to do and stop the influx. And I know this is a conversation we've had with colleagues and officers, and Anna's really passionate about this as well. So that's what I'd like to see, Chair. Thank you.
So we do have some powers. We have a supplementary planning document around hot food takeaways, which we're about to review, which has a number of aspects to it, but including things like proximity of takeaways to schools. But we definitely need to look at that cumulative impact effect through that policy with planners. I think the other aspect we'd like to look at is the amount of advertising in deprived areas. And there's been a number of articles in the media recently about this association between increased advertising of unhealthy food and other harmful products in more likely to be in deprived areas. So they're just two of the things that we're really, really keen to look at.
Thank you. I think we'll be interested to see how that moves along going forwards. It's interesting because there was a report, wasn't there, last week, a week before, about ad block and how there's more bright adverts in the inner city areas, like the area myself and Councillor Arif represent different parts of the inner city, but still the inner city. Thank you. Okay, I'm going to bring in Dr. Beale next.
Thank you, Chair. Can I thank all those who've produced not just this appendix, but also the other 3 appendices as well. I think they were all very helpful. One quick question, then one perhaps longer one. On page 25, it talks about sponsoring and advertising. Are there any major organisations, and I'm thinking perhaps the sporting organisations, it could be others, such as football, Leeds Football Club, rugby, cricket, Yorkshire cricket team. So are there any major organisations that advertise what we might term as less desirable, high salt, high fat, high sugar foods? And secondly, I was talking to one of my colleagues before the beginning of this meeting, and she was talking about how her children learnt to cook, and they learnt in the family, and they used to help mum when they were very small. They first of all watched, then they helped, and they learnt to cook. And I'm sure that's the best way of children learning how to cook. So my question is, firstly, for children, many of the mums and dads probably as well cannot cook themselves. So how do their children learn? And it seems to me that the only way that they can really learn is through schools actually teaching them. Going back into the Middle Ages, when I was at school, it was only the girls that learnt to cook. That would be totally inappropriate nowadays. Boys and girls ought to. The question is, to what extent is cookery part of what schools do provide to assist in healthy eating at home and in the future when those children are parents themselves? Let's break the cycle of families which don't cook and don't know how to cook. And secondly, as far as adults are concerned, one of the ways in which adults who don't know how to cook is through third sector organisations. But we know that third sector organisations are being hit with reductions in their grants. So what effect will that have on those people who might have gone to cookery classes, let's call them, who won't be able to in the future, and they won't learn how to cook? And indeed, I'm aware that a number of those households don't even have the wherewithal to cook. They don't have sets of pots and pans and so on. So what effect is the cuts to the third sector going to have influencing adults who might have learnt to cook, so that the families can be properly fed with healthy nutrition and the children will in their turn learn how to cook?
I'll pick up the first question, which was mainly around advertising in sport. I think you're probably more likely to find a gambling advert on a sports shirt. In terms of the grounds and the adverts that might be in the grounds and the food that's served at grounds, for example, we're doing some work with the Leeds Rhinos to exactly look at the stadium and the environment of the stadium. So that's something that Emma, who's I think in the audience, is working very closely with the Leeds Rhinos on, and we'd like to obviously do that with all the clubs locally. Catherine, do you want to answer the children's
Sure.
ones?
Yes, you raise very good questions, and I think the problem is it's so large. I think it would be disingenuous to think that every single child in Leeds is taught cookery skills, but there are a few things that are happening. So Henry, which we talk about, frequently, which is targeted at families where children are at risk of living with obesity. Parents are taught about the Eat Well plate, and they share ideas about cooking. There are our locality team has projects where they will go out in the community and have bags of ingredients with recipe cards around how to cook and prepare meals. We commission the Family Healthy Living Service that works with children, and one of those projects delivers cooking skills. Another project, Dance Action Zone Leeds, delivers cooking skills to parents while they're waiting for children. The way that we do this more systematically is with the Health and Wellbeing Service that covers healthy schools, and there's information about cooking. There are family food leaflets, healthy packed lunches. There are standards that we advise school meals to adhere to, and that is the way that we are trying to mainstream and reach all children. But there is more that could be done.
Thank you very much. Okay, are you satisfied, Dr. Beale?
Yeah, just if I could ask, I mean, you mentioned Henry, for instance, as one of the third sector organisations which does actually provide that training for families or parents. To what extent are they going to have reduced level of provision because of cuts to their grants?
To be honest, nothing imminent, which is good news. So the model, Henry is a national charity. We pay not very much money at all to have a licence, and it is run on a cascade training model. And so colleagues are trained, and then that information is fed down into our children's centres, which currently we have universal coverage across the whole city, which we're so proud of. And it links into the system. So we have obviously, we have health visitors, which offer a universal service with 5 mandated checks. Those staff see individual families in the home. It's not quite working with antenatal at the moment, but all of the other checks. Children at risk of living with overweight or obesity are identified and supported. There are pathways, and we're also very proud that those pathways are shared by the 0 to 19 public health integrated nursing staff and the children's centre staff. That we call them Healthy Start pathways. And so the Henry support can be accessed through that, and we are unaware of any family that wants that hasn't got it. We don't have a waiting list for that. So that's something that is working really well currently.
Super, thank you very much. Okay, Councillor Ritchie.
Thank you, Chair, and thank you for the introductions. My question, well, first of all, I think I'm remembering rightly, pre-COVID, we were celebrating Leeds bucking the trend in reducing childhood obesity. So if that's the case, what were we doing then compared with now, and what's changed in that time other than I'm aware of COVID? And can we just go back to what we were doing then? Secondly, it's on the Henry courses. They're also being funded through health partners as well, out through local care partnerships, certainly the Leeds West one, funded one. But I'm actually interested in the data on the uptake of those. It's all well and good putting on the courses, but if people aren't attending them. So I'd be interested to know if that's monitored and what percentage uptake is taken. I realise you won't have that information right now, but perhaps it can be brought back, because I do know one of the LCP ones wasn't very well attended, and that's not to the detriment of those that put it on, they did the advertising and what have you, but it just wasn't well attended. My next point, on page 29, talking about infrastructure, and I'm really passionate about levelling up in our city on our parks. So at the moment, capital funding for parks is usually through development planning gain. So in areas where you don't have a lot of development, you don't get that investment in parks, and it's usually the more deprived in the city, certainly in the city areas that don't have any room for building. So it's mainly a plea to the council officers and the exec members to join my ask for a push that it goes up on the still I think we have a 1, 2, 3 list, and I do realise we're having to fund the lack of building schools for future and a lot of the money has gone into that. But I really think the focus should be beyond Section 106 and development, and a citywide ambition to bring up all our parks to top quality, because I think that's when you'll get children going to the parks and being healthy, and their well-being will improve greatly. And then just a final comment, reading the paper, this first section, it's clear to me that the government policy is really weak. It kind of says that without directly, I suppose. And my conclusion is that the lobbying that the Westminster lot subject has been more powerful than doing the right thing. And perhaps you'll agree with me that if it were dealt with the same way as smoking, because the health effects seem to be similar, we might get some change with that. Thank you, Chair.
Thank you for your questions. You're quite right. Leeds did buck the trend, and it was something that we were really proud of around childhood obesity. You've asked what has changed. Nothing has changed in terms of support. We still have children's centres, we still have Henry, we still have a focus, all of the healthy schools work. What has changed is increasing poverty, stress, austerity. Councillor Arif mentioned the differential impact of the lockdown experience on children living in flats with no access to parks. So my view would be that is what has changed, and as I mentioned at the beginning, we are on par with the England average, but we have got more poverty in the city. So we still are doing things right, but there is so much more that we can do. You mentioned the local care partnership course in Leeds West. What course was that? Was it a Henry course or?
Yeah, it was a Henry course. Yeah,
Right.
yeah,
Okay. All right then. Yeah. I have to be truthful. I don't know. And I remember when we brought the Director of Public Health annual report here, that was your question, wasn't it? Around Henry, how do we know is the families that really need that are going to that? Do you remember? I remember. That was a question, and it's a good question. And so off the back of that and our kind of curiosity, that is a piece of work we're doing. We're looking at the Henry courses, and we're seeing which families are attending. It is targeted at our more deprived communities, and it is targeted using the National Child Measurement Programme data, which is excellent data that we get, but we aren't sure about uptake, and we want to look at that. So it's something we can report back on. The capital funding for parks. Public Health aren't in charge of parks. We'd like to be. Somebody else might want to answer that question, but this is something that Councillor Venner was interested in as part of the Thriving Strategy work. If you remember, because of that impact of COVID lockdown, the differential impact, and when we looked at the data, actually, the data, the kind of, I think it's ONS data show that actually more deprived areas have got more access to parks. But when you look at data around access to green space, it is the more affluent areas that have got access. And that's something that's a priority, isn't it? In the Thriving Strategy, you've got colleagues from Parks and Countryside looking at that, and there's work on the place efficiency strategy. I don't know if somebody else would like to comment on that. And then your final comment, was that your final comment? Sorry?
The national policies.
Then, oh yeah, okay. Do you want to answer that, Anna? Yeah, good point. Your national.
Thank you for mentioning the national approach and particularly smoking, because that's a great example of where policy has changed, things like advertising, the norms around smoking, and it's also helped the effectiveness of the Stop Smoking service. It's still the #1 cause of preventable ill health and death. We do need to remember that, but we do need a similar approach around food. Absolutely.
Thank you. Just on the place efficiency, that is something that the council is the first council in England to be pursuing that, and it's clearly something that needs to keep moving forwards. But it's definitely something we need to push, because every child deserves sufficient play space. I agree. Victoria, do you want to come in?
Thank you, Chair. Just briefly, it was just to come back again, because it feels really important, on Councillor Rich's question about what was it that made us buck the trend, what was our learning from that, and then how are we applying that now and into the future. As Catherine said, what were the two main themes that came through around why Leeds did book the trend around reductions in childhood obesity, but particularly for children living in deprived areas. There was two main things. One of them was that there wasn't one programme or one service that was kind of the magic bullet on this, but in Leeds we had that whole portfolio of interventions that Catherine's mentioned around Henry, children's centres, healthy schools, 0 to 19 service, etc., all the work in neighbourhoods, the community food projects, etc. And that combination of all of those things, what was something that was felt to be really strong in Leeds that was less strong in other areas. So it was the breadth of the programmes that we were committing to. The second headline from the learning was that we actually committed to those on a long-term basis. So they weren't short-term, non-recurrent bits of money. They were invested into kind of over a decade in order to give us the outcomes they did. So we've not changed that formula. What has changed is the proportion of children and the numbers of children who are living in deprived Leeds. So our rates of children living with obesity and overweight should be much higher than they are. As Catherine said, that we absolutely want to drive them down further, but we're still in a positive position, reflecting our demography from where we other areas are with the same demography. So it's those two key points really are things that we're very keen to keep hold of going forwards. Thank you.
Thank you very much for that, Victoria, despite it being a sort of bleak outlook at the moment for young people in deprived areas. Okay, I'm going to bring in Councillor Fowler next.
Thank you, Chair. I think this is really important work that's taking place across the city because we're facing a real crisis with obesity, then leading on to real health concerns, diabetes. Prior to this meeting, I was actually talking to Councillor Scopes about the impacts of diabetes and how it's going to impact on the NHS and wider care services. So I've really got three comments leading into questions from my own experience. So I suppose firstly, in my ward of Bermondsey and Richmond Hill, we're working with an organisation called Community Shop. And what they're doing is they've introduced cooking lessons at our youth clubs. So it takes place once a week over a period of several weeks, and it's really about looking at the education for young people, how they can get involved in cooking, think about like healthy lifestyles. This is also then replicated via Healthy Holidays, which I know Cross Green Growing Together runs via Hyde Park Source. Again, really great local organisations that are operating and thinking about how we can improve the education around food and around actually making your own food at that level. I suppose it leads on from what Dr. Beale was saying with regards to looking at school education. So this then leads me to ask what more work can be done across the city, working with third sector partners to encourage healthy lifestyles, and then perhaps even looking at tying that in with social prescribing. I know, for example, go for a walk around the park is part of not to minimise it, but that's part of the repertoire. But is there social prescribing for going to the gym or additional sort of like gym training? I know I'm in the gym 5 o'clock in the morning, and you see a lot of users who are not necessarily well skilled in using equipment, but perhaps that's something that we can look at as a city providing access to. So I've got 2 other points, but I'm going to leave my comments there for now because I appreciate that's quite a big chunk of question.
So I guess so there's a GP element in terms of prescribing. I don't know, Jim, if you want to comment on that first, and then I'll bring in Catherine and Anna again, if that's okay.
Yeah, thank you. So primary care networks and practices do have social prescribers and health and wellbeing coaches. that do offer advice around weight management. Whether they've got access to actual services like gyms, etc., will vary from place to place. What we do find, though, is that where there is a lack of services or resources in one part of the system, it'll impact on general practice and have a consequence with them also. So it ends up being a bit of a circle that we can't break. So while social prescribers or health and wellbeing coaches are focusing more on supporting people with weight management problems, they can't support them on other issues that are maybe core to the work of a primary care network or practice, for example. So it's a tension, it's a difficulty, and it's down to the resources available often within a particular practice.
Thank you. And our next one is tier 3 weight management. So I think we'll come back to this point about the system, which is a really valid point, and it's one of the biggest challenges with funding reductions. Catherine and Anna, did you want to comment on that at all?
Actually, I think Steve is going to come in about the gyms access. That was the next main point, wasn't it? I think.
Yeah, thank you. In terms of the gym access, in terms of social prescribing, there are a number of different health programs that we kind of support from an Active Leeds kind of perspective. And we have been working on a pilot kind of scheme in terms of an exercise referral kind of program that we have been working with primary care networks and the likes to kind of get that self-referral route, but also social prescribing and making sure that in terms of physical activity, that is a big part of it, and where that is access to the gyms or where that is actually supporting the community and going to a community fitness program or the likes, then we do have a program that is currently in a pilot phase on that front. So Leeds encouraging activity in people, which is put into the report when it comes to our part of that report. So there are schemes in there that we are supporting through that side of things. And obviously you're aware of the Department for Transport initiative in terms of the social prescribing element there as well. So we do try and make sure that that is very personalised to what the individual needs and what they want. So very much there is a number of different schemes that we do there, but again, it all relies on funding to allow us to keep those kind of programs running, which obviously are heavily subsidised from our side of things to keep them moving on that front. Thank you.
Thank you. Councillor Farley.
So yeah, I mean, I suppose the question is still there around kind of partnership working with third sector around kind of healthy choices when it comes to food. But I was just contemplating something that Councillor Arif said earlier with regards to her own experience in Hare Hills. Near where I live, there's a takeaway shop that sells burgers for 99 pence. You can buy 3 pizzas for £10, and this is clearly leading to bad choices when it comes to diet. I suppose the question is, and perhaps you're not really in a position to answer it directly, but is there work that has been looked at or can take place around, say, licensing and planning with regards to shops promoting like unhealthy lifestyles, and then thinking more specifically about my ward of Bermondsey and Richmond Hill, and reach across the border into Gibson and Hare Hills. What work specifically is taking place to look at some of our inner city communities where weight management and the some of the associated health impacts can be really quite difficult, or people might be more prone to for example diabetes, which is quite heavily prevalent within South Asian communities. So what really has been done to look at kind of these particular areas? Thank you.
The first point about the burgers and the pizza takeaway, which you talked about, would link to my initial comment about the supplementary planning document. So that's something we're currently or about to review and would hope to strengthen. In terms of there's also, I suppose, advertising sites in presumably in your area that the council may have control over.
I mean, we've got a number of kind of the bright advertising, advertising hoarding. I mean, my argument will be, and it has actually been with the ad block campaign, they're not actually promoting anything that I view as particularly harmful. Generally speaking, it's bank loans or cars or actually there was a huge advert for the gym. The real issue is when you go onto Hales Lane or on York Road, and what you find is there are numerous advertisements on shops and posters and whatnot for bad choices. You've got vape shops, you've got grocery stores, all of which are promoting bad choices when it comes to health.
And that's something we would also look at through planning. We've actually just got a new post which is going to work across planning and public health to look at exactly that type of issue. Just coming back to the choices offered by takeaways, etc. If we had more resource, we would like to look at things like Healthy Catering Award, work with colleagues in environmental health, actually go out to takeaway and other food outlets and restaurants as well. But they are very stretched. So there are options we could look at if we had more resource.
Thank you. Do you want to move on to your? Do you want to move on to your other question? Oh, the third sector. Is that what? Yeah, third sector partners.
I think I can't remember how many listed in the report, but we do have some food projects with the third sector. So I think there's an example in West Leeds. Sorry, I think it's a recipe cart. My colleagues would know more than me, but there are some specific examples. But Catherine, do you?
Yeah, they're the things that I mentioned before with the localities team, the bags of ingredients that are taken out with recipe cards, and the family healthy living services that the children's team commissions that has an element of cooking skills. There could be a lot more of those, a lot more resource. The difficulty is that how we deploy the resource, because we don't have very much. So we try and pick things that would work with partners and cover greater numbers of people. So, for example, the work we're doing around healthy schools, if we have more money, it would be great to do, but we haven't got the resource.
We might want to just give you a list outside the meeting of the projects that we are commissioning currently.
Thank you. Okay. Do you want to go on to your other two questions? That's it. Great. Okay. I'm going to bring in Councillor Taylor next.
Thanks, Chair. Thanks for the report. It's really good. Enjoyed it. I'm going to just throw it out there for everyone to pick it up on your own department. It is hard for you, isn't it? It's really hard because reading the report, we want the best for our young people and adults, but we only can do so much. And you are doing the best you can. However, here's 6 and reception. They are children. They parent accountable for them, their diets. We've got GPs in the room. We know it's not just eating make you overweight through lack of sleep, energy, and all different factors can come across it. You also talk about advertisement and the television. If you notice, they cut down the fast food advertisement. They do it differently. But then you go out in the town center, you go into urban, they're all over. Advertisement, you don't need it on placards, for the shops is just there. So what are we doing working with parents? For instance, I know we talk about third sectors. I cherish third sectors, but there's not enough finance to get to all third sectors. They are doing a brilliant job, but you've just said it, there isn't the finance. So central government need to step in, one with planning, the manufacturers, supermarkets, the pound shops, you name it. That's where it's all started from. Because if those products not there, the kids can't get hold of it, can they? We fight to move ice cream van from schools over the years because they used to finish school and get into ice cream. We do need planning. We do need restrictions in supermarkets to move all those silly junk foods, pound shops and all these things. And we need to educate parents to cook properly instead of going to fast food, because a fish and chips is £10. It's cost of living. £10 could give them 2 healthy meals if they cooked it at home. Gyms are very expensive. Again, it's cost of living. We need a bit more equipment in the park, because if parents don't accompany it, some year 6 and reception children, they won't able to get in the park. So the real route is coming really from the adult to educate the young kids. Do you know what I'm trying to say? But I admire you all for the work you're doing. You're doing a brilliant job, but it's a challenge. And we need to look for the root before we fester. Thank you.
Thank you, Councillor Taylor. I'm not sure that's a question, but I think there's all statements of fact. So I think everyone's nodding. So I'll accept that as a comment. Thank you. I'm going to bring in Councillor Anderson next.
Thank you, Chair. I've got a number of points I've noted down. Now, the last time I looked in our leisure centres, there are vending machines with chocolate and crisps and cafes selling what you might call unhealthy food. So we can't be saying one thing and doing another. We need to practice what we're preaching. Now, I'm not against that, actually, because I think people should be free to choose what they eat. I don't think the state should be telling anybody what they can eat and what they can spend their money on. But it should be seen as a treat and not an everyday thing. You know, there's nothing wrong with McDonald's. There's nothing wrong with a pizza. There's nothing wrong with a takeaway. If it's once a month, that's a treat and something to look forward to. It shouldn't be an everyday thing. And as Councillor Taylor rightly said, if we're in the middle of a cost of living crisis, people haven't got money. So I don't really know how they can afford these things. And it's really sad that we have to train people how to cook, because, I mean, I was lucky enough my mum taught me a little bit of cooking. She was a really good cook, but I kind of picked it up as I went along, but we did get cooking at school to a certain extent. Down at Kirkgate Market are actually doing a really good job with the cookery school down there. And they're also, they've got recipes, and they're also actually taking people around the different stalls to show them where they can buy the ingredients. So that's like it's a win-win, because the market's getting something out of that, the traders are getting something out of that, and obviously the customers are getting a lot out of that. In terms of low alcohol drinks or no alcohol drinks, unfortunately, a lot of things like cider, no alcohol cider, is absolutely full of sugar. And that's the, massive downside to that. Because it's not all fat that's bad. I mean, sugar is quite a bad thing. People, you do need some fat in your diet, but sugar is a real problem. And just we had a session at our Outer Northwest Community Committee on the 6th of March, subgroup for health, and Andrew Walker came and spoke to us about social prescribing, and that was really interesting. I think the members got a lot out of that. So thank you.
Thanks, Caroline Anderson. I think there's quite a lot of comments there, but I think it's worth asking Steve about the point around the leisure centres and the foods available. Thank you.
Yes, it is something that we work very closely with public health on, in terms of making sure from a tender point of view, when we do review the kind of contracts for the vending machines, that all meets all the guidelines in terms of lower sugar options, healthier snacks. So there are healthier options in there, and the size of the bars and different things also meet those kind of requirements as part of it all there. So we do try to limit as much as possible, but it's still on our kind of radar to kind of keep reviewing that to try and remove them. Unfortunately, some of the healthy options, sometimes when they're in the vending machines or giving people options to have a bit of a snack, they don't obviously sell by date and nothing else, that is causes a bit of a challenge. But yeah, in terms of the vending side of things, we'll continue to kind of review that side of things, as well as making sure from an income perspective that we're not kind of penalised by that as well on that front.
Yes, just under the healthy weight declaration, we have done some work around all Leeds Council vending machines. And I can send some information around after the meeting, but there's a set of buying standards which restrict things like calorie content, etc., of products in vending machines. But I won't go through it now. I'll circulate after the meeting.
Yes, thank you. And I think there's a whole public health issue about sort of the how much you've earned. So I think a lot of us, certainly I do, I go for a run and then I think, oh, I've earned myself this much, but actually it's got much more calories than I've actually burnt off in the run, which is deeply disappointing. Okay, do you want to come back, Anna? Yep.
Oh yeah, I think you have to run a mile to burn about 100 calories, that's a lot of running. You...
Those can't hear. Councillor Bennett's explaining a marathon, you get 3,000 calories for that, which I think's maybe a decent, maybe half a takeaway. But there you go. Okay, I'm going to move on to Councillor France-Mear next.
Well, I just want to say thank you for the report today. I completely agree with what Councillor Taylor had mentioned and Councillor Anderson as well. And I'm just, Councillor Anderson mentioned the Kirkgate Market outfit that's there. But also it's just going back to healthy schools, and the fact that it's all right teaching and supporting the children and making those lifestyle choices. But we've also got a culture shift where we've got parents that are making, unfortunately, the wrong choices when it comes to purchasing and being able to cook and recycling meals for a few days. And we don't want to become a nanny state. We don't want to teach parents how to parent. However, some of the healthy schools, play schemes and that perhaps should be opened up to parents and children, because it's at the end of the day, the wallet's with the parents in choosing those ingredients and so on. But thank you for the work that you're doing. I know it's extremely hard and it's extremely difficult in trying to manage something where there is a culture of all these TikTok videos and other, is it Snapchat, where they buy this and have this sour sweet and this, that and the other, and it's virtually impossible to do what you're doing. So thank you very much.
Thank you for those comments, Councillor France-Mear. Snapchat. There you go. Okay, I'm going to move on to the next appendix. So I'm going to move on to Helen for the next session. I think you've got some slides, is that right? Hopefully.
Thank you so much. I'm actually going to, Ram's going to present and I'm just going to kindly share the slides. Just a piece of context, this is follow-up from conversations that we've had with you previously around the specialist weight management services known as Tier 3. I'm sure councillors will recall. So given that you had a lot to read from other colleagues, we thought we'd give you some light relief and something to look at. So Ram and David are going to take you through a set of slides and then we'll be happy to answer questions.
Thank you. If you want to move to the next slide, please. So from last time we had a conversation about this, I appreciate that we talk in tiers. So I thought it would just be worthwhile setting a bit of context around what we mean by tiers. So there are 4 tiers to weight management provision. Tier 1 being the universal prevention services, which we've talked a lot about today around access to healthy food, signposting to healthy information, etc. Tier 2 is then around intervention, specifically around dietary, lifestyle, exercise programs and advice. And then the NHS really then starts to come in at Tier 3, where we commission at Tier 3 specialist multidisciplinary weight management services. And then even more complex than that, we've got Tier 4, which is surgical options, so your gastric band type operations. So in that tiered system, the idea is that the more complexity somebody is living with, the higher up the tiers that they go. So particularly where patients are living with morbid obesity, with other health problems and things, that's where that multidisciplinary kind of support really comes in. So in that tier there is psychological support, dietitian support, physio support, medical support. There's support around drug treatments and things like that. Usually an 18-month, 12 to 18-month program. And then some of those patients may go on to have bariatric surgery or may be identified as being more suitable for bariatric surgery. So obviously in that tier model, as the complexity goes up, we struggle to see huge amounts of patients, and the cost of that goes up. So as you know, we previously spoke to Scrutiny around a decision to pause tier 3. So today we're just going to go through what we've done in terms of recovery and where we are with that. So I will pass on to my colleague, Ram.
Afternoon, everyone. In terms of just to give you a bit of a context about the tier 3 criteria, which is commissioned by ICB in NHS, if somebody needs to be 18 plus, should be Leeds GP registered, and a BMI of over 40. And if they have comorbidities between 35 and 40 also is considered actually. I think the handouts is a little bit wrong in terms of the BMI, but we have amended it on the slides actually. And they should have demonstrated. Previously, we had this as one of the criteria that they should have had engaged very well in tier 1, tier 2 prior to coming to tier 3. However, unfortunately, tier 2 was decommissioned sometime in 2022, which had a significant impact on the tier 3 offer, which we provided through Leeds Community Healthcare. And if we go on to the next slide, actually, that provides the timeline and the demand we have had actually. I think it started off somewhere in March 21 actually, and then it continued to do. And between September 22 October, when the tier 2 offer was stopped, that's when I think the service couldn't cope with the increased demand. Initially, the service was commissioned to provide only 250 patients a year, but we started receiving around 125, 100 to 150 patients a month. And because of which the service that was provided for the people within the caseload became very diluted. And it wasn't as intensive as we would offer. That's why we went through scrutiny board, and a very unfortunate decision was made to pause the service actually so that the staff could concentrate on the current caseload. If we move on to the next slide, that provides a bit of context. In the last 8 months, the services worked very hard to reduce the caseload by around 19.7%. That's what it says on the slide. But since doing this report, it's come down further, that we have reduced the caseload by 23.7% actually. We have done an EQIA to mitigate all the risk, and services concentrating on clearing the backlog and also working through the new Wegovy pathway, which is a medication offer. The NICE TA came about last year, and therefore Leeds Community Healthcare is working with ICB in terms of commissioning the Wegovy pathway, which is medication offer has to be provided through the tier 3 multidisciplinary team. So that's what we're working on. And the service also is working through redesign to reopen the service. And it's very difficult to give a time period when the service could be reopened. But we are looking to see probably by the end of this financial year, we might be able to 24, 25, we might be able to tell when we could reopen. And if we go on to the next slide, that gives a little bit of timelines, actually, what we're going to work between March and June. It's through implementing. We have identified the opportunities to improve efficiency and capacity. The NICE TA, the 875, which is a Wegovy pathway, is being embedded in, is going to be offered soon. It's going through the PEG and other executive partners actually for final sign off in the next week or so. Between July and December, we are tracking the progress, and probably by Jan 25, we might be able to tell when the service could reopen. And just to give a bit of a context, which is not in the paper, I think the chair asked to provide what's the criteria for tier 4. If you go on to the next slide, that gives a summary of if somebody who hasn't lost any weight, BMI of over 40, or if they have comorbidities above 50, non-smoker, alcohol managed, HbA1c less than 60, and they've engaged with tier 3 around 75% at least actually. And they go through the bariatric surgery actually, and they shouldn't have had any surgery in the past. All those criteria. It's a multidisciplinary team offered by the hospital in Leeds. And we have a joint assessment from tier 3 and tier 4 colleagues actually, so that the right people are chosen actually for the surgery, and they're followed up for 2 years actually, at least. And as we discussed during the tier 1, 2, 3, 4, actually, each of the tiers is approached in such a way that there's less than people who needs goes to the top of the tier 4 rather than a square or rectangle. If you go to the next slide, actually, that gives a bit of data in terms of for a quarter, around 36% only move on to surgery, which just carries its own complexity, and 64% are seen by tier 3, either undischarged, either because they've reduced weight to an agreeable limit, or they are able to sustain and they don't need surgery. That's just to provide snapshot. We don't have any national data benchmark the Leeds tier 3 offer, but we are working through it. Thank you. Is there anything you want?
Great. Thank you very much for that, Ram. Very helpful. Just a question to start us off and open it up to members again. Around, so on the tier 4 categories, one of them is engaged with tier 3 of at least 75%. I just want to know the impact of the current pause of tier 3 on people who need tier 4 surgery. Thank you.
It's probably worth talking about capacity in tier 4. So capacity in tier 4 is a surgical pathway. So patients need to access surgeons, theatre space, historically also critical care space, but I think less so now with new surgery. So we're capacity constrained in all parts of our pathway. So I don't know the numbers of people waiting for surgery already in the system, but there will be some. So the other thing that's really important, and I think was really helpfully recommended through Scrutiny colleagues, was to make sure we had a fast track pathway. So we do have high risk patients and a way to track people all the way through. We've always had a direct access into tier 4 for people who are clinically high risk, and that remains that pathway. So all of these are arts, not sciences, and there's always a continuous conversation. So if there was somebody who was identified as requiring immediate surgery for whatever reason, there is a way through that, isn't it?
Yes.
Yeah.
Anybody who has got renal complications, or anybody is waiting for another surgery like hip surgeries or back surgeries, they will be prioritized actually for bariatric surgeries. So they have it's a multidisciplinary assessment actually, but it's looked at case by case actually from priority. It's based on the clinical priorities.
Thank you very much. I can't see anyone else indicating, so I think it'd be quite helpful to go. You go on, Councillor Ritchie, sorry.
Sorry, I thought you were going to ask again. Could you just explain what the surgery is? Is it gastric band reductions, or is it can there be other interventions? That's the first question.
They have quite a few surgeries depending on what is required. I think there are 5 or 6 actually, but I'm not able to answer, but I can find out and tell you from the hospital colleagues. But the bariatric surgery covers the whole lot. It depends upon the individual, what they could cope actually.
So that were just a bit of context for my next question, because I was wondering if we had the numbers of how many people opt to go private for these operations. That's why I asked if it were just the one operation. And do you find that people go abroad to have them? And if anything goes wrong with either through the private sector or abroad, does that then impact on the service here, the capacity here?
So we obviously don't have data directly on people accessing private sector surgery or indeed care abroad. I don't have the data on complications, but we can certainly ask colleagues to see if they have any data on that. We don't routinely have that data, but I can ask for the second question. I think in terms of private sector access, there was always a strong private sector market for for bariatric surgery, and I can't imagine that that has changed. I think it's the aftercare that is also really important. So all of these pathways should have multidisciplinary aftercare, behaviour management aftercare around them. And I think one of the concerns is surgery on its own is probably less effective. So we did have a long conversation with independent sector partners about how making sure that they also provided the aftercare and that people didn't then bounce back into NHS funded aftercare, just creating a different set of bottlenecks. So I think when we talked to the chair, I don't think he understood quite how multifaceted these are long-term problems, and the surgery on its own without the aftercare probably means that they are less effective and less effective. So we can definitely ask about data on complications and whether there is any data that the local team maintain. It's not been escalated to me as a specific issue, but I can check with the surgical team. Happy to do that and come back to the scrutiny officer.
Thank you. So just to come back there, because you mentioned aftercare, which isn't necessarily a complication. Does the aftercare sometimes fall on the NHS, and is it affecting the service delivery? Do we know? Because I presume even if someone has an operation privately, will it be registered with the GP that they've had this surgery at some point, or not necessarily?
If it's a good private provider and it works properly, then I think the answer would be yes. I'm looking at my GP colleague. Yeah. I mean, there's aftercare directly related to the procedure, but then there's aftercare in terms of a weight management service. So I know, for example, Spire and Nuffield here would have made sure that they have a proper psychological therapies offer and a proper dietetic offer and a proper aftercare offer of things you need to monitor as part of their pathway. Can't speak, obviously, for all of the independent sector providers, either in the UK or abroad.
It's just to add, that's why people go through all the tier 1, tier 2, tier 3 offers, so that they are well prepared psychologically to go to the tier 4, and it's sustainable after the surgery. That's why they have this strict criteria, NICE has recommended. And when they have the tier 4 surgery from NHS, I'm not sure about the private provider and what happens actually, but they're usually followed up for 2 years in terms of the support what's offered from the hospital.
Thanks for that. And when we had our chairs brief, we talked a lot about the lifestyle challenges to any of the tiers actually. So unless you change your choices, your weight isn't going to change. So you need to have the diet and the activity both combined. I think I talked with Anna about this in chairs brief as well. The need to have it like the whole package. So surgery by itself won't change anything unless there's also the lifestyle factors. And I think it's really important to remember that there's not a silver bullet. It's even with we talked about the new drug, even with that, it's about changing lifestyles as well as that in the short term together can make a longer term difference. Good. Okay, I'm going to bring in Dr. Beale next.
Thank you, Chair. I understand the situation with regard to the 4 tiers, but there are 2 mentions of the Wegovy pathway in the slides that we've just shown, and I'm not quite sure how that fits in with the tier process. And it does say that if it's supported by the Integrated Care Board at their meeting later this month, or in March, it might already have been held for all I know. I can't remember. I'm not on it any longer. I wonder if you can explain to me what that actually means for the residents of Leeds who will be able to access this particular pathway.
Yep. So I'll just give a little bit of introduction in terms of what the drug therapy is. So it's been approved by NICE for use in the NHS, and there's been a lot of media coverage about that, and particularly in not just the traditional media, but also on social media. The new skinny jab, game changing. The way that the drug works, it's an injectable therapy, and it basically acts like an appetite suppressant. So while you're on the drug, it will reduce your appetite, therefore you will eat less and lose weight. Now, all the clinical trials, the drug was used alongside the wider tier 3 support to lose weight. So all the lifestyle, the eating healthily, the exercise, psychological support went along with it to produce the outcomes. So there's no evidence around if you just use the drug on its own, it will have the same impact. But I think some of the perception out there of it's a magic drug, I have this drug and I'm going to lose weight. So that's why it's really, really important that we embed it as part of a comprehensive service, because also when you come off the pathway, there's no long-term evidence. If you just use the drug, when you stop it and the appetite suppressant goes away, you just will regain the weight if you carry on the same behavior. So that's why it's really important that we, you know, look at this pathway in the round and introduce it sustainably. And also, I think just to give you a rough idea, you know, there's about 60,000 patients who would meet the NICE criteria in Leeds. And the cost of delivering that whole package to those patients would be in the region of 150 million if we was to do that. So clearly it does have a really important place in therapy, and we're working across West Yorkshire to come up with a implementation strategy that would mean that those at the highest need would be able to get access first. So that's work in progress. And also, so we don't create inequalities, whereby, as we know, the inverse care law, those who often need healthcare the least access it the most. So yeah, we're working on that, and progress is being made.
Yeah, just to confirm, so we have the ICB committee at Leeds Place tomorrow. We have, despite the enormous financial challenges of the ICB across West Yorkshire and in the Leeds Place, made a small amount available to set up a team to support the first cohort of people to take the drug, because it's a NICE TA, which stands for treatment advice, I think, something really, yeah. Technological advice, there you go. There's a requirement on bodies to follow NICE TAs, and we have to explain how we're following it. But as David said, what we don't want to do is take the whole cohort that's not ethical and that wipe out pretty much all the other discretionary commissioning that we do across the whole pathway and clearly across the whole system. So what colleagues have done is worked on a more refined set of criteria. So we've put some money into our budget for next year to set up a small team to start that multidisciplinary support, so that we can start a cohort of people, so that we're in accordance with the requirements of a TA, but in a way that we think is responsible and targeted for those who would benefit most. And obviously significant proportions of our patients in tier 3 are from IMD1 and IMD2. It is part of our inequalities work. So that's what we've done. So the reason it's going to committee is obviously it's part of the wider budgetary arrangement. So it's about the only piece of growth that we've put in to next year's plan. And we've also made a small amount of proposal to make some more of the tier 3 non-recurrent funding recurrent, recognising the enormous pressure on those clients. I think behind people's question was, how soon can we open? Clearly, it's not satisfactory not to have an active tier 3 service. Nobody thinks that's a good thing. So we've just tried to squeeze a bit more into the system. It's small numbers. The numbers in tier 3 are small compared to the size of the prize, but that we are where we are. So that's what we've done. That's why it's going to committee tomorrow, because it's part of the wider budget. It also needs, because we're not a statutory body anymore, the criteria and the way in which we're implementing it have to be approved through the West Yorkshire Committee for the actual prescribing. So we're working closely with colleagues to suggest that we do it in the way that we've suggested, which is a narrower cohort of people than are recommended through NICE, but we think a more appropriate cohort of people.
Thank you. Do you when you're deciding how much money to invest into tier 3 and tier 4 budgets, do you consider the impact of obesity across the NHS, whether that's on heart services or diabetes experts or the stroke facility, etc., etc.? Because obviously weight does have an impact on all those services, and all comes with associated costs. Thank you.
The short answer and a long answer, I think. The answer is yes, but in a situation where we're not close to meeting balance at all, we're looking at what else we can do. And so it's a balance of the least harm as well as the most benefit.
And I think that is a real tension. I know that colleagues have struggled with this, all of us, and we're struggling with this every day at this point. So we have a statutory obligation to meet financial balance in the year, as well as the statutory obligation to try and do things that are sensible over the next 5 years. And they don't always match, I think, would be where we are. So yes, we're absolutely aware that those people are at greater risk of harm as individuals and across the population.
And just to be clear, you can't, like the councillors can do investor save because it's allowed to borrow because it's going to save money in the future. The ICB can't do that, even if it believes it will save significant money over the next 5 years.
It could, if it could also achieve financial balance in the year.
Okay, I'm not going to push anymore. I think I understand your answer. Okay, I'm going to move on to I can't see anyone else indicating. I'm going to move on to Jim and his paper, which starts on page 47, for some initial comments, and then we'll go into questions. I think it'd be quite helpful if we just picked up the initial comment around ways to fast track people through the tiers and your experience as a GP, or whether that's possible, or the GP Confederation's point about whether that's possible, and then any comments, and then we'll move into questions. So thank you very much, Jim.
Thank you. I'll do a brief summary of the briefing, and I'll bring in Dr. Julia to give some examples of what it's like actually in practice on the ground. So I think there's a bit of a perfect storm in all of this, and you'll gauge through the briefing the sense of what it's like in primary care for patients, people, and for colleagues that work in the service. So there's the bit that's been described around all the public health type issues and the choices people make and the social factors, education, cost of living, etc., and what that means around choices around food or exercise. There's a second bit about tier 2 and tier 3, and I think the tier 2 bit is really critical, because that's the access, that's the preventative stuff that is so important. And in the absence of those services, as well as tier 3, notwithstanding the explanation that's just been given, it leaves general practice with little choice as to where the support for individuals can receive any sort of care or services. There is then the third element, which is the overall context of general practice. So it has multiple demands and multiple priorities put upon it. Increased complexity often of older people with frailty, for example, and their own workforce challenges too. Continuity of care is sometimes difficult. So combining those three bits leaves with a perfect storm, which is multifactorial in its nature, as has been described. There are some mitigations to the issues which we tried to do. So different types of workforce, and we've spoken already about health coaches, social prescribing. Some primary care networks are considering employing dietitians, so there's more of a clinical approach to some of the care, and also motivational coaching within the health check environment. But this has consequences, and the consequences are stated in the paper. And when I spoke with many GPs and the LMC and the clinical directors of the primary care networks, this is one of their biggest problems, because poor weight management not only leads to a longer term physical health problem, but also mental health problems. And that whilst there's a fast track into tier 4, there'll be lots of people who are waiting for tier 3 services who can't lose weight for whatever reason, and their health will deteriorate over that period of time, and the whole thing snowballs. And there's an example in there. But I'll pause for now, and I'll just ask Dr. Julie if there's any other comment.
Yeah, I mean, I think the paper puts it very well. There's obviously, as a GP on the front line, it doesn't stop patients coming in to ask for help with their weight, and particularly in areas where funding or the finances are tight. So we talk about inequalities, the areas like Bermontoffs are the areas that need the help. And we don't have anything to offer them. Really, we do have health coaches, but they weren't really employed to do this work. This is additional work that they've been asked to do. Only the other day I saw a lady whose BMI is 50. She would qualify for a tier 3 service, but we can't provide that. And it's the second time she's been in, because we can't tell her when that service might come. And who knows how many times she might come in if it's going to be 2025 before that restarts. And obviously the biggest problem we'll see in the short term would likely be with people with things like osteoarthritis, and then they'll be too heavy to have the operation. They'll have to stop work. In fact, the public health economic case calculator for tier 2 services makes the case for the biggest savings are in wages. And the biggest impact of that must be in areas like Bermontoft, Hare Hills, Richmond, other areas of the city where people are very poor.
I've got nothing else to add. So.
Great, thank you. Thanks. I think that's really helpful, both talking about the system challenges and also the mental health aspect. So thanks for raising that, because I don't think we'd brought that in yet, the mental health aspect, which is really important. And we've talked about system challenges before in this meeting around as budgets get tight, each part of the system starts watching its own budget rather than the whole system. Can you just, as a starting question, I open up to questions if members want to ask the two GPs here. Just a starting question: what's the practical challenge around getting more sort of weight coach and non-GP appointments for people across Leeds in your practices? And I guess just to spell it out, we're lay people here, so in my head, a weight coach is less expensive to pay than a GP, and so from a pure layperson perspective, it appears that that would be a cheaper option. So if you could just help me out with that, thanks.
Yeah, primary care networks, which for those that don't know, they are geographical groupings of maybe 5 to 9 GP practices. They have access to funding for additional roles. So the additional roles are different workforce to support the GP as a clinician. And there's a list of roles, and there can be anything from pharmacists to health coaches to physiotherapists to dietitians, and in fact, nurses are included in that list now. So the primary care network has a choice to make, and there will be lots of different types of demands. Mental health is a huge one on that particular primary care network. So they have to make workforce recruitment choices, some of which is done in a coordinated way in the city. Hand on heart, I don't think all of the workforce challenges and coordination of different types of workforce in primary care is as coordinated as it could be, which leads to differentials in different primary care networks as to what workforce is available. But you're absolutely right. If health coaches are recruited and if they are trained in motivational coaching to encourage people to lose weight, then that would be much more economic to do. And primary care networks do that sort of work. But what it means where there's pressures and demands in one part of the system around weight management, then it will have a consequence somewhere else, because there are only so much workforce to go around because the funding is only limited. The other factor is the primary care network direct enhanced scheme, which is their contract. It was only agreed a couple of weeks ago for the year we're about to enter. So there's lots of variables around which people are reluctant maybe to commit to employing someone full time when that funding stream might not be guaranteed.
Can I just make the point? We as GPs directly might have made a short intervention, something that you could fit into a 10-minute consultation, but we would never have taken on, treated or helping someone to lose weight. So that would have previously been referred on to the tier 2 service. But now that doesn't exist. It gets referred to the health coaches. All we've done is change the funding from the council to the NHS, but there is no more funding in the NHS. So there are no more health coaches. I presume the people offering the service are paid in a very similar way to the tier 2 service was.
Yeah, thank you. And just to be clear, in terms of the funding for those extra staff, is that ICB directed?
It's from NHS England through the ICB, but essentially it's an NHS England thing transacted by the ICB. There's very little gift to do anything different with it.
Okay, thank you. I'm going to bring in Councillor Ritchie.
Yeah, thanks for your report. Thank you. So I'm just reading the summary, and you cite the loss of tier 2 impacting the service. When you look holistically at how we run, how other countries run, and the rhetoric that you get from Westminster again around the need to boost the economy, and they talk about increasing productivity, improving health so that people are able to work. And you've, as well as in the report, you mentioned those aspects in your summary. So they know what we need to do. We've talked about invest to save. There are strategies that we know if we implement will improve things, will save money, will do all those things to boost the economy. So you've got to ask the question, why? It's not rocket science. Why aren't we doing it? Why aren't we doing it? The crucial thing for me is local government funding is the foundation that everything is built on. If we get that right, everything else will fall into place. We got the public health devolved, didn't we? And since then, I think it's been cut since it was introduced. So I think we're probably all on the same page. So what happens? Is it when they walk through that door, the pearly gates of Westminster, or what? Is it Watford Gap when they go past there from the north that they don't get what councillors are telling them that are dealing with these issues day in, day out? GPs are telling them, health professionals are telling them, and nobody seems to be listening. And that's what needs to change. Start by funding local government properly, and then everything else will fall into place. And the evidence is there for it. It's not a political statement. It's not rhetoric. It's a matter of fact. Thank you.
Thank you. I think I'll take that as a comment, if that's all right, Councillor Ritchie. Thanks for that, though. Can we bring in Dr. Beale?
Thank you, Chair. And to some extent, it goes back to what Councillor Ritchie has just been saying. When I read the Appendix 1, which was from the Directorate of Public Health, it talked a number of times about the importance of diet and mentioned high fat, high sugar, and high salt. And as a retired dentist, it mentioned high sugar, and I thought, maybe there's a role for dentists in this. As a regional consultant in dental public health, each of the regional consultants had leads in particular aspects of dental health. And one of the areas that I had responsibility for was dentists and smoking. And we produced guidance encouraging dentists to refer appropriate patients to the smoking cessation services. And I thought maybe dentists who've got patients who may well be obese, but have got high dental caries rates as well, maybe there's a role for them to refer to an appropriate service for advice. They wouldn't take kindly to the dentist saying you're fat, you ought to go and see someone. But if we say you've got a lot of tooth decay, then maybe they would understand the dental implications. And when I came to Appendix 3, I found The GPs have exactly the same problem. They don't know where to refer the patients to either, because the services aren't there. And it seems to me, Chair, that it's the age-old problem. When money is tight, where do we put it? Do we put it into trying to heal, trying to improve the life of those who've already got the disease? Or do we put it into other ways of preventing the disease from those who haven't but might well be on the line to getting the disease? And it seems to me that we've lost now tier 2 and tier 3. And at the bottom of the appendix, it's critical that we now do all we can to help patients who need to lose weight and welcome your support to reinstate the essential service. We could do that, and we could say we would welcome it. But it's mentioned that general practice, I think it was Jim originally, and now presumably your colleague who's on the long-term conditions population board. And it seems to me that what we ought to be saying at least is that the long-term condition population board, and I'm sure they've looked at this already, but that they look at it again, and we encourage them from the scrutiny board and say, we are concerned about this. Would the population board look at the way forward on this and how we can improve the situation?
Thank you, Dr. Beale. And I think that's a very good idea. I was thinking, Victoria's just indicated, but I was going to ask you anyway, just to give us some context around the tier 2, because obviously the counts, it's being inferred by our colleagues Marcus and Jim about the tier 2, but we haven't addressed it head on. So welcome to make the comment you're going to make anyway, but could you also comment around tier 2 services and the challenges, because it's been talked about, but we haven't addressed it. Thank you.
Thanks, Chair. So just to add a few comments, Anna may want to come in because she's been most involved in this. I think to talk to the point of the resources around public health and prevention, Councillor Ritchie's point, we absolutely have seen reductions to that budget since public health came to the local authorities 10 years ago. 11 years ago now. So on average, that's about a quarter of the resource that has gone. That's a national issue, but our Leeds position reflects that. On top of that, Leeds is funded at the lowest level of any core city. So we've already got a low starting point on which to lose that, on which to make that reduction. On the tier 2 service kind of context, there was absolutely, in terms of the work being done by the population board and Anna kind of leading the public health contribution to that, working with NHS colleagues, we were very actively looking at a better way of providing that kind of tier 2 type service, because you'll see from the trajectory of the graph that was shown before that even when we had our tier 2 service, we were still seeing referrals going up. It wasn't a magic bullet. And actually, the nice guidance around tier 2 is quite modest in terms of the contribution you would expect to see in terms of the outcomes for people who would actually have a successful kind of weight loss. So we knew that we weren't really reaching as the outcomes we wanted to reach with our historic tier 2 service, and the work was going on across the city to come up with a proposed model for doing that better. And we've always said, as and when there's opportunities to do that, we would absolutely want to get around the table and look at that model again. So it's not about going back to the service we had necessarily, but looking at how we can do that better. So I think that's still a very live offer, but obviously it's very dependent on resource. And that's still, as we stand today, that's the resource is the fundamental challenge. You know, in an ideal world, we wouldn't have had to make any of these reductions, but we obviously live in a time where we've had to do some very difficult things. The only thing to end with is that I know that across Yorkshire and Humber and West Yorkshire, there are some areas with no tier 2 or tier 3 service at all whatsoever. So even though this is very challenging, it's not the very worst of our kind of geographical neighbours. So this is a very much a kind of a national issue. Anna, I don't know if you want to add anything to that. No, thank you.
Dr. Beale, do you feel like your comments been addressed?
Well, half of it has, but the referral back to the population board, I think, is absolutely crucial. I assume that public health is part of that board, as well as the NHS people who are involved. And I do think that it's important to talk that through yet again. Whether it results in any new money or any more money being found is another matter. But I think that we ought to be asking the public health representatives from the City Council and those who are there from the NHS to look at it again, and with the impetus behind it, saying the Scrutiny Board were very concerned about the current situation. What can we do about it?
Yeah, I just wanted to come in as the chair of the board. So yeah, absolutely, we will do, and I think that's in our plans. You know, we're in a bit of a recovery phase, but our long-term plans is to look at that model again, pick it up, and see, you know, where we can make improvements. I think what's really important to mention is that, you know, obesity is a chronic relapsing condition, and you know, obesity as a whole is just going up and up. So actually, a benefit, you know, a positive outcome might be a flattening of the curve, you know, and I think that seems to be some of where the economic modelling kind of comes from. It can be quite vague, particularly in terms of that long term, what intervention actually has the biggest impact. But overall, the thoughts of even a small weight reduction over somebody's lifetime, you know, builds up and to have a significant impact. So, you know, they're the things where the sooner we do things with people, the earlier on, you know, if it's only half a kilogram over over 40 years, that can have a significant impact, rather than there's no magic bullet that's just going to cure obesity overnight. But I think it's collectively what's the sum of all the parts that's just going to help us keep that trajectory subdued and bring the most health benefits to people.
So just for the board, are we content to write a letter as per John Peel's description? I'm seeing nods, unless anyone dissents. No, good. Okay, so I think we will write to you, David. I think there's just in terms of like summing up a little bit, I think it's worth commenting that I think we've heard from the ICB, Victorian Public Health, and the GPs that funding is an issue on this matter. And it's really frustrating from the board's perspective, because it feels like there's a weight of evidence that suggests tackling obesity will save money in the long term because of other chronic comorbidities. And so I guess we've got to find a way of expressing this to, we need to think about who we can write to about this, because I do think it's an act of corporate, like, we're missing something if we're not working all together to find more funding to tackle this. And so I don't know if we need to write to the appropriate minister raising this as a concern, but I think it feels like it's like everyone's saying there's a funding issue, and that's not just a political organisation, which Leeds City Council is. It's also the ICB and GP Federation, which are not political organisations. Okay, so we're going to move on to our fourth paper now, and hopefully this will be a little bit more positive around I call this tier 1. I'm not sure it's technically tier 1, but like lifestyle choices, and we've talked about how active lifestyle is important in the fight against weight. And so I'm going to start with Councillor Arif, and then we'll move on from there. Thank you.
Thank you, Chair. So yeah, the report provides an update on the physical activity ambition for Leeds, which is being led by Active Leeds and Public Health. It includes details of the work programmes and achievements delivered against the priorities of active environments and active people, which were selected as the initial focus for the physical activity ambition, which we discussed and agreed by which was agreed and discussed by the Physical Activity Ambition Steering Group, the Health and Wellbeing Board, and also the this Scrutiny Board back in 2022. As we discussed earlier in the discussion, there is clear evidence that being physical active is essential for good physical and mental health and delivering the best city ambition, which is Leeds as a place where everyone moves more every day. Whilst the latest physical activity data highlights that Leeds compares well with other core cities and neighbouring local authorities, there is much more to be done on inactivity levels. The levels of inactivity in the city remain highest in the most deprived areas, which is where we are focusing our resources. The report describes progress across the 7 work streams of the physical activity ambition. One example that I want to highlight is the Department for Transport funded active travel social prescribing project in the Bermondsey, Hare Hills and Richmond Hill primary care network area of the city. The project aims to increase physical activity levels through prescribing walking and cycling in primary and secondary care. Links between infrastructure and development, both new and existing, will also try to encourage more active travel. Looking forward to a good discussion. Thank you, Chair.
Jane, do you want to make any opening comments? Or Steve? Yep.
Thank you, Chair. Yeah, I won't go over what Councillor Arif's just kind of described, but yeah, there has been lots of positives that we've kind of done in terms of some of the work effort that I just wanted to highlight, but also just to say that this is the physical activity ambition. So this is as part of the city wide kind of initiatives in terms of the partnerships we've got across third sector and GPs and everything else that we've brought together. So that's the whole kind of picture. It's not an Active Leeds kind of general kind of update, which obviously is a lot of other areas of work that we're kind of progressing with. But some of the key achievements, like Councillor Reeves already highlighted, Department for Transport element, but also the children and young people side of things, in terms of young minds get active. Which in terms of the campaign, the report kind of highlights, you know, that was a fantastic piece of work that kind of delivered with children in kind of making their own videos around physical activity and their effects on mental health, which again, the campaign has been really well received, and in terms of the reach of young people has been really highlighted on that front. Similarly, in terms of the Aging Well and Strength and Balance campaign, it's one of the best kind of campaigns in terms of the reach that we've kind of be able to have as part of all that. So again, it just shows that the physical activity element is kind of making and is getting to the people that they kind of need it. And then lastly, like we kind of spoke around in terms of earlier in terms of our LEAP program, which is our Leeds Encouraging Activity in People pilot. Again, record numbers coming through. Unfortunately, waiting lists has been created as part of all that kind of demand in terms of physical activity and the need for it, which is currently working in a couple of 4 primary care networks, currently working in that kind of clinical pathway, but specifically around diabetes, mental health and hypertension elements that we're kind of getting referred into that at this point in time. And that is a self-referral program as well, so you don't have to go through that clinical pathway. But the numbers that we've kind of reached so far and the impact we've had from the research that Leeds Beckett have done is showing that we are actually targeting the right people. We are getting to the inactive people, and we're making lasting improvements in terms of their physical, but more importantly as well, their mental health kind of benefits on that program. But unfortunately, very similar kind of elements in terms of resources wise. That is a pilot program, and we need kind of to make sure we can sustain that program because it is reaching the people that we require it. But yeah, it's stuff that we kind of are working through at this point in time. But yeah, thank you for taking the time to read the report. There is a lot more we can do and a lot more we need to do in terms of the inactivity side of things, and especially in the inequality side. But that's where we are trying to put our focus attention at this stage. Thank you.
Thank you very much. I'm going to open up to questions, but just a couple of comments as if in case members want to think about it. So on page 52, it's positive to see the activity rate increasing. I think there's still a challenge to keep pushing it up back to pre-COVID levels and hopefully beyond there. I think that is a really important aspect. Just like to say, it gets at local stuff. Certainly in my ward has been really positive. Some excellent officers have been involved in that work. Along with volunteers, which has been really, really positive to see, and people getting active in different ways. We've had a skate club in my ward, which has been really good. And the other thing I think that's just worth mentioning is they've done well getting outside funding, so from all sorts of sports associations for our facilities here in Leeds. Councillor Ritchie, I'll bring you in.
Thank you, Chair. Yes, I agree. It's an excellent report, very positive, great ambition and great delivery thus far. If I may, here to be a critical friend, I would like to see it augmented perhaps by a report specifically on people with a learning disability, because it's referenced on page 21 about the high levels of obesity in that group. And I do think, and I know there is work going on through Disability Partnership Board and so on, but I'd like to see that referenced in the report and just maybe tweak out any barriers to access and so on, how we could add that. So that'd be my constructive comment towards the next year's report. Thank you.
Yes, you're right to highlight in terms of the learning difficulties element, and it is an area that we kind of prioritise in terms of those priorities in terms of the active pupil side of things. So we are doing a lot of work in that area, and yeah, we need to reflect that in the report. So we'll do that for next time to make sure that that highlights that element as well. But again, there's huge amounts of work that is happening, but we can always do more on that front.
Thank you very much. So I think we're moving towards the end of this section, but I'd like to give an opportunity for anyone who of our guests and partners who want to make any further comments about the conversation, any other observations that want to make based on what they've heard today. Just give people an opportunity. I'll start with Jane, and then if you want to, please indicate.
Thank you, Councillor Scopes. I suppose the other element that the physical activity strategy it touches on, and a couple of members around the table have mentioned around parks and green spaces, which are a critical part of physical activity, health and well-being, but they're also used by millions of people in our cities every day, whether that's sports pitches, sports clubs, coaches, dog walkers, tennis players, and they're a really important asset. And Councillor Ritchie will recall fondly our time spent together building up 6 levelling up bids across the city that were unsuccessful. Fortunately, we've been able to secure some funding for the Holbeck scheme, and we're still working on other schemes in the background, so the work's not wasted. But that was all directly about investment into green infrastructure, and it's the one area that we could really prioritise investment into and get maximum benefit out of with little partner intervention. So there are probably about 200,000 people that use our sports pitches every year, and they're a really important part of our infrastructure. And those sports clubs probably fall under the radar of conversations like this and probably need a little bit more space to be able to articulate what they do. So I just wanted to touch on that because I thought it was important.
Yeah, thank you very much, Jane. And I, with my school governor hat on, we'd call that the universal offer. So the basic offer that everyone has available to them, and absolutely do value that and the investment needed, which is exactly why I sort of linking it back to the investment we're getting from third parties, and I think that's really important. I can't see anyone else indicating. So I'd just like to take a moment to thank everyone for coming. I really appreciate you sitting through the whole thing. I've found it really helpful, and I've found your comments and insight useful. I feel like we've got a suggested way forward, at least a little bit of a way forward from Dr. Beale to keep us moving forwards. So yeah, thank you for your time. Thank you for your papers, and thank you for your input. Okay, I'm gonna let you guys go now. I think most of the items now are internal, so you don't need to sit through them. Obviously, it's a public meeting, so you're welcome to sit and enjoy the next phase of our meeting if you wish. Okay, so I'm going to move on to item 8. So this is the end of year scrutiny report. I'm not going to say anything about it because you've read it. Are there any comments to be made? If there's no comments, we'll take it as agreed. Okay, yep, super, thank you. Okay, I'm going to move on to item 9, which is the work schedule. Now, this is always a challenge because obviously we don't know who's going to be on the successor board. That's a democratic process to be gone through, and it's useful to give some items, particularly for the first couple of meetings. But if you've read it and or have any comments and or have any work items that you'd like us to recommend to the successor board, please tell me. But just note that the successor board will have discretion at their first meeting after the elections to decide what's actually on it. Thank you. Councillor Farley.
Thank you, Chair. So just for information for the rest of the committee, I had a quick discussion with the Chair prior to the meeting, following a conversation that I'd had with consultant nephrologist working in Leeds, Dr. Sunil Daga. And I bumped into him at the opening of one of our new surgeries in Hare Hills. And he is very interesting because he wants to talk about kidneys and good kidney health. Currently, some of the key stats for around chronic kidney disease, it currently impacts on 10% of the population, and that's between stages 1 to 5. But predicted dialysis growth is going to be around 400% within the next 10 years. And by 2040, it's going to be the 5th leading cause of premature death for the general population. So what I'm going to suggest is, because I think there's a public health role here, that we could look at this as part of our ongoing discussions around improving public health, but also looking at how we can prevent how we can help to prevent kidney disease across Leeds. So,
thank you, Councillor Amos. Did you want to come in?
Yes, if I may, it just so happens that Dr. Daga was my mum's early consultants, actually. My mum's had a kidney transplant. I think it's something that we don't perhaps talk about much, and I think it's really important that we do. And from a public health perspective, I think this is really important agenda. So I'd fully support that recommendation. Thank you.
Thank you. I thought it'd be really I thought it'd be a really interesting item, and I thought we need to think about whether we bring it in with sort of wider health messaging, because there's a lot of health messaging that does get out about chronic diseases, but this isn't certainly one that I'm aware of, and maybe that's me, or maybe I haven't had my haven't been educated, probably a bit of both. And also, I think there's a number of chronic diseases in the city which we might want to look at. So we'll definitely make a note of that. Are there any other items anyone wants to put on now in case they're not on the successor board? No, good. Okay, so just like to say thanks. I've had a good time this year. I feel like we've covered a lot of different items. I feel like we've had some good debates and challenged appropriately, as we should. So thanks for your support. I won't see you again until in this committee until after May, unless there's a call in, which I hope there isn't, just there for ease, I guess. But thank you very much for your time and commitment to the board, and I hope you have a good next couple of months. Okay, thank you. There's so there is a chance that, so thank you very much. I'll take that, Councillor, could you?